So without further ado, let me call up our first dynamic duo of speakers, and all our speakers today will be up here together talking about atopic dermatitis and psoriasis. So if Dr. Silverberg and Takashita could come up, please. I'll introduce both of you. So Dr. Silverberg is an assistant professor of dermatology, medical social sciences, and preventive medicine at Northwestern University Feinberg School of Medicine in Chicago. He's also the founder and director of Northwestern's Multidisciplinary Eczema Center, and as everyone knows, a highly prolific author about atopic dermatitis, and particularly about the epidemiology related to it. For psoriasis, I'm happy to introduce Junko Takashita, who is an assistant professor of dermatology and epidemiology at the University of Pennsylvania, where her clinical focus and her research focus is on psoriasis.
Good morning. Okay, it's nice to see such a nice turnout for atopic dermatitis and for psoriasis, of course.
Yeah, don't forget about psoriasis.
Well, you know, for so long, the conversation's been about psoriasis alone, and it's always going to be a hot one and an important one. But to see atopic dermatitis get its day and really, you know, that visibility and attention is very gratifying. So these are our disclosures. Most of these are not really relevant to anything being discussed today. So we'll start off with the basics of incidence, prevalence, and natural history. And we'll do a little bit of a back and forth, which hopefully no one will get dizzy. But just talking about, first we'll start with atopic dermatitis. There's a lot of things we know in terms of the basic epidemiology, and there are a lot of things that we don't know. When you look at the incidence globally, some recent studies have put it at around over 2,000 to 3,000 children per 100,000 person years. So fairly high incidence. In Germany back in 1997, data showed as high as 17,000 per 100,000 person years. When you look at sort of the children or adults, right, because most of the work's really been done in the pediatric cohorts, but when we're looking at adults, we have even less data. And in Japan, as high as about 10,000 per 100 person years, and this is for adults and children combined. In the UK, going back to 2005, over 13,000 per 100,000 person years. What we're lacking actually in the US is we don't have any great incidence data. We have some prevalence data, which I'm about to show you, but we don't really have any incidence data to know just how commonly these disorders or atopic dermatitis comes about. When you look at the prevalence, so I'll walk you through this panel here first. This is just, these bar charts really highlight some of the differences between different assessment approaches and different study designs and some of the different numbers that have come up. When you look in children, probably one of the best studies to look at for this exercise is the National Survey of Children's Health. It's a nationwide household survey, randomly sampled, somewhere between 90 to 100,000 plus households. And estimated prevalence from the 2003 to 2004 National Survey of Children's Health was about 10.7% of all children. But when you look at 2007 to 2008, the actual number bumps up to about 12.98. Different study design, National Health Interview Survey, which is an in-person household survey, slightly different methodology. For some reason, always very similar question, but somehow always underestimates that prevalence compared to National Survey of Children's Health. When you stratify, because we have many years of rich data to look at trends, you see that in 1997 to 1999, a prevalence of about 7.4%. When you fast forward to 2009 to 2011, you're up at about 12.5%. So both of these studies really showing that there's an increasing prevalence over time. In adults, I think this is an area that is a little controversial because, so, you know, I'm showing you numbers that I actually published, and it's something that it turns out atopic dermatitis is a very hard disease to assess from an epidemiologic standpoint for a number of different issues. But looking at the 2010 National Health Interview Survey, which used a less specific question, the prevalence was estimated at around 10%. When looking at the 2012 National Health Interview Survey, which is a more specific question, it's around 7%. And I think the number is probably closer to 7%, but the 7% might underestimate a little, the 10% might overestimate a lot, so it's probably somewhere in that range. Well, what's interesting is, you know, we think of the United States as being sort of one country and everything's lumped together, but you're covering a major, you know, a broad spectrum in terms of landmass, geography, climate, environment, et cetera. And so there's a very broad distribution of prevalences and ranges. And so this is a heat map from the 2003-2004 National Survey of Children's Health, which was published by Eric Simpson's group, and found that, so when you look at the blue states, those are the lowest prevalence states, the green are in the middle, and then you have the red states, which are the highest prevalence. So you see there are certain relative hotspots around the coast, and then there's this little hotspot right here. And this trend, generally speaking, holds up as well for 2007-2008 National Survey of Children's Health. We see that there clearly are regional differences even within the United States. Interestingly enough, it's almost a color invert in some respects from the electoral map, but that's a separate issue. So when looking at the prevalence, I showed you for the United States that the prevalence seems to be increasing from those data. But in fact, there's evidence now to show that really globally the prevalence has been increasing for quite some time, and really, even in recent years, continues to increase in many countries. And so this was a very nice systematic review that looked at really any locations where there were multiple studies that were published over time, where there could really be an assessment of, did the prevalence change or did the incidence change over time? And there are a number of countries that are highlighted here where in fact the prevalence did increase. So UK, Germany, Morocco, Kenya, China, Japan, Taiwan, Australia, etc. So each country has to be approached sort of individually to understand those nuances and what drives the prevalence or incidence in the population. But this is something that whatever those risk factors are, they're either increasing or something is changing, but the prevalence and the incidence seem to be increasing globally. There, at least in the United States, appear to be some racial and ethnic differences in terms of the prevalence. And so these are data from the 2007-2008 National Survey of Children's Health, which found that, compared to the racial and ethnic background and breakdown nationwide, and this is a fairly representative distribution for the non-atopic dermatitis children, but for those with atopic dermatitis, you actually have the highest rates in the African American children at about 22%, so more than double that. Actually, the way this is broken down is the percentages are a little, I think one of them is a little off here, but the actual prevalence of atopic dermatitis in Caucasian children is about 10%, a little less than 10%. And in African American children, it's almost 20%. So you have an almost doubling the rate percentage-wise. And these kinds of associations are highly reproducible from multiple studies. I mean, it almost doesn't matter where you look, you find these associations in children. But what's fascinating is you don't for adults, and it's totally unclear why not at this point. Some other reproducible associations seems to be a higher prevalence in older girls and in women. There's an urban versus rural gradient where there clearly seems to be higher prevalences in metropolitan areas. And then there's some controversy about some of this and how it works, but higher household income and socioeconomic status in many areas has been shown to be associated as well with higher prevalences of atopic dermatitis. In terms of the natural history, what's fascinating about this graph, so these are data from the National Health Interview Survey 2012. And what's beautiful about this study is they asked this question finally, not just in children, but also in adults. And you look at the prevalence of atopic dermatitis, and what you see is, not surprisingly, the prevalence peaks, in early childhood. And it sort of dips down here. Around adolescence, there's a precipitous drop. And then it drops to around 7% in adulthood. This is that study that was the source of that 7% number I quoted beforehand. But when you watch it over time, it holds steady. So it really seems to be not just something that slowly peters out prevalence-wise over time, but really holds its own throughout the adult years. And so the question is, and especially when you look at the two studies, population-based studies in the U.S., showing much higher prevalences than anticipated. It seems to be robust and hold up throughout adulthood. Why? Why is this higher than we previously thought, or at least sort of the old dogma found in textbooks? And so there's really a couple of possibilities. Either it doesn't, the disease does not burn out, the childhood disease doesn't burn out nearly as much as we thought, or there's a lot more of the so-called adult onset disease, but something's got to happen in those adult years to keep those cases going. So talking about the persistence of the disease, these are some data from the PURE cohort, which is a phase 4 post-marketing study which was done for Elidel. And looking at the persistence here, What this study particularly found was that at every age, more than 80% had symptoms or were using treatment for their AD. So really provocative, suggesting that 80% with persistent disease, this is not burning out nearly as much as we would have thought. And by age 20 years, only 50% of subjects had at least one lifetime, 6-month symptom and treatment-free period, right? So they weren't reporting any symptoms, they weren't using any meds, totally clear, so to speak. So only half getting to that point. Now there's some questions because the cohort was one that used, a second-line nonsteroidal agent, in terms of the recruitment, could be it's not a population-based sample in the classic sense. So perhaps there's this overestimates, but it's quite provocative, suggesting that it really does persist more than we would have anticipated. So we did this exercise recently where we did a systematic review and meta-analysis, looking at basically all the studies that were out there that we were able to cull data at the persistence of the disease over time. And from all of these studies combined, got slightly different numbers, that by 8 years, only 80% of children achieved an observed period of disease clearance, right? So this is that time to first clearance. And what was fascinating, so these numbers are a little bit closer to what you would have expected from the textbooks, but with this approach, we were able to identify several risk factors. So one, there were 3 studies that looked at severity, stratified by severity, and not surprising, the more severe disease was associated with more persistent disease. But what was interesting was age of onset was one that was a predictive factor. The older the age of onset, the more likely they were to persist. And another aspect was the number of years they were already persistent predicted that they were going to continue and stay persistent. So, there may be a patient who's already pre-wired to be persistent for reasons that are not fully known, and once they've declared themselves to last for that long, the odds are they're going to stay that way for perhaps life. But a limitation of this approach was we couldn't examine the recurrence after that initial period of clearance. Most pediatric studies found that about 50% of cases begin in the first year of life, and that's really what you see quoted always, about 85% of cases beginning within the first 5 years. The challenge with these studies is almost none of them have actually looked at the adult period. So there's this assumption that if you can extrapolate the lessons learned of a pediatric cohort to the adult cohort. Well, as it turns out, you get the exact opposite finding in most of the adult cohorts out there. Most of the adult cohorts show that if anything, you have higher rates of adult onset disease. And there's some uncertainty here because perhaps the patient had it as a child or as an infant, long since forgotten about it, and this is not really adult onset, but really adult recurrence. But from my perspective as a clinician, the take-home message is we don't care, because when a patient walks in as an adult and meets full criteria otherwise, even if they declare that they've never had it as a child, they can in fact be atopic dermatitis and should be managed as such. It's something that can be, a lot of different patterns, can be intermittent or chronic persistent disease activity. There's one study from the isolate study that showed that moderate patients have on average 8 flares a year, severe patients have on average 11 flares a year. And what's interesting about utilization patterns is many of these patients don't even make it into the healthcare system. So data from the 2010 National Health Interview Survey showed that about a quarter of adults who reported having, eczema or itchy rash were not seeing a physician for their skin issues. And part of that is related also to limited access to care in the US, but there may be other factors at play. So with this, I think we're going to turn.
All right, so in an effort to stay dynamic here, we'll switch it up a little bit. And so we'll start by talking about psoriasis, basic incidence and prevalence. Similarly to atopic dermatitis, we have much less data for incidence than we do for prevalence, and I'll show you prevalence in the next slide. Unlike atopic dermatitis, most of our data are really for adults, as I'll show you here. So if we just look at incidence first, the incidence and prevalence of psoriasis was nicely summarized in a relatively recent systematic review here referenced at the bottom. So for all adults, if we either look at all adults or across all ages, really we see quite a range of incidence rates coming from the United States here at the top, coming from medical records, and this is really a population-based study that was done in Rochester, Minnesota. We have ranges from about 60 to nearly 80 patients per 100,000 person years, sorry. There have been incidence studies in the United Kingdom as well, and this is coming from primary care medical records, and their incidence rate was about 140 per 100,000 person years. And then a study done in Italy really reported the highest incidence rate, also coming from primary care medical records, about 200 to 300 per 100,000 person years. And I'll talk about in coming slides how we define psoriasis and also different study populations, how that impacts our measurements. There have been, again, very few studies done in children. The incidence study in children was done in the same sort of cohort that was done in the United States in Minnesota, again, that was done for adults. And this incidence rate was estimated about 40 per 100,000 person years, so less than in the adult or general population. Now, what about prevalence? So we have a lot more data to tell us about prevalence of psoriasis, both in the United States as well as worldwide. What you can see here are some general patterns, is that psoriasis is generally more prevalent in the Americas as well as in the European countries, with prevalence rates ranging from 2 to 4%. Much less common, but also less well studied in Asia, China, Japan. Australia has similar prevalence rates as we do here in the United States. And then also, again, very few studies in the African countries, but a much lower, estimated in Tanzania at about less than 0.5% prevalence. Now, there have been fewer studies looking at racial ethnic differences of psoriasis prevalence. A couple of studies here in the United States, highlighted here on the left. I don't know if this mouse is not working. Okay. So what we've seen is that in the United States, whites generally have the highest prevalence of psoriasis, and it's less prevalent in the racial ethnic minorities, so 1 to 2% in blacks and 1.4 to 1.6 in the other racial ethnic minorities, and this also is in contrast to atopic dermatitis. Now, in terms of psoriasis severity, and we're mostly talking about plaque disease here, it's estimated that about 80% have mild disease, and we'll talk about disease severity definitions in slides to come. Moderate disease is prevalent at about 15%, and about 5% of patients with psoriasis have severe disease. Interestingly, even though blacks have a lower prevalence rate of psoriasis, it's been suggested that they have more severe disease. Now, what about pediatric prevalence? So there are very few studies compared to the adult population, and generally in the pediatric population, the prevalence rates are much lower than they are in the adult population. Again, you see a little bit of a range here, and it kind of depends on whether you're measuring a point prevalence or a lifetime prevalence being in the squares. And as you might expect, the lifetime prevalences are a little bit higher. Now, I alluded previously about how we measure psoriasis and what study populations we use and how that impacts our incidence and prevalence rates of psoriasis. So I just wanted to show an example of how this can result in different measurements. So at the top here, I kind of talked about in the previous slide, there are certainly differences of whether we're measuring lifetime prevalence or a point or a period prevalence of psoriasis. And these are summaries of just some of the prevalence studies that have been done in the US, the upper panel. And again, as you might expect, lifetime prevalence rates measurements are generally higher than period prevalences. Now, what about how we define psoriasis? So there are many different ways to define psoriasis using large databases. So if we look at the NHANES, which is a population-based survey study done here across the United States, they define psoriasis by a patient's self-report of whether they've received a physician diagnosis of psoriasis. And based on that cohort, prevalence rates have been measured at about 3%. Now, if we go to the next line down, using medical records from Kaiser Permanente in Northern California, so they use definitions based on medical record diagnoses. And so their measurements of prevalence have been a little bit lower at about 0.94%. Similarly, using Medicare claims databases, so administrative claims diagnostic codes for psoriasis, again, prevalence rates are a little bit lower. The reason for this is because these are people who are going to seek medical care, so there are a number of patients who may not be seeking medical care or may not have psoriasis as significant enough of a problem that it's getting recorded in the medical record or for billing purposes. Now, what about the natural history of psoriasis? So, unlike atopic dermatitis, this is really mostly an adult disease. The average age of onset is about 33 years old, and the majority of patients present before the age of 46. As you can see here in the bottom graph on the left, this is kind of the incidence rates by age, and you can see in general incidence rates increase until about the 7th decade, and similarly prevalence also increases through about the 6th decade. Majority of patients have plaque psoriasis, about 90%, and this is a chronic inflammatory skin disease. It has a waxing and waning course. However, in one report or one study, nearly 40% reported spontaneous clearance at any one time, and this ranged from anywhere from 1 to 54 years. But the longer periods of so-called clearance generally is pretty rare for psoriasis. There are a fair number of patients who are undiagnosed with their psoriasis in the US. It's estimated for up to about 2.3% of patients do not carry a formal diagnosis of psoriasis. And then in terms of treatment, generally psoriasis patients are undertreated. So a couple of reports here. So prior to biologics, at least 50% persisted with active disease despite getting treatments. And even in this age of biologics, I'll show you another graph later, most patients are undertreated. So we'll move on to disease severity.
Okay. So don't get dizzy, but we're going back to atopic dermatitis. So let's talk a little bit about severity. Severity in atopic dermatitis is a very important issue, certainly one that's always been an issue, but one that's emerging even more as we move into an era where there's new options for some of these different things. And the challenge we have right now is we don't really have a universally accepted definition for atopic dermatitis severity. I'm not sure we'll ever get there, but at least there are certain concepts that can be applied or generalized. It's important from an epidemiology standpoint, and certainly important from a clinical standpoint, because different severity definitions are going to impact your definitions in terms of prevalence and epidemiology, but also in terms of who gets treated with what. But severity encompasses really several different aspects. I mean, you can have a scenario sort of like this patient here, and hopefully you can see the mouse, great, where the lesions are relatively mild but fairly extensive, covering almost the entire body. So you can have lesional extent that can really take you up there because the person is just itching all over and is impacted on every inch of their body. Or you can have a scenario where you have these more oozing, crusting, nasty lesions in themselves. So the lesions themselves can have a certain severity component. But with atopic dermatitis, perhaps most importantly, or to the patient at least, is that symptom burden. So itch, pain, sleep disturbances, mental health disturbances, and that impact on quality of life. And so there's numerous scales out there, and the challenge with any of the formal ones used in trial criteria, similar to the fact that you couldn't really use them in a clinical practice setting very often, you're not going to be able to use a lot of these in epidemiology studies. So what we're often limited to is self-report. Now the question is, how valid is self-report? So we actually have validated this question, and I don't have enough time to finish this and get it out, but it's like 90% done. But it's amazing how well global self-report by the patient correlates with score ads, EASIs, patient-reported outcomes, you name it. I mean, there's some nuances in terms of which ones work better, but it really correlates highly, strongly with that. So this question of, how would you rate your eczema as mild, moderate, severe, is a reliable one. And this one was used in the National Survey of Children's Health, 2007-2008. And the prevalence that was estimated for moderate to severe disease was that about 26% of children with atopic dermatitis had moderate, 7% with severe disease overall, as reflected in the pie chart. But what's interesting is there's an age difference, because while we expect that a lot of cases of atopic dermatitis will, quote, burn out, the ones that often do persist, as I mentioned earlier, are the ones that are more severe. So when you look at the prevalence distribution based on age, in the younger kids, you actually have a lower proportion in the moderate to severe group, but when you get to the adolescents, you have a considerably higher proportion in that moderate to severe group. And so this is something that certainly is clinically important, but actually has certain ramifications, this increasing distribution, as you'll see in a second. So what does this reflect to? It comes out to basically about 9 million children with any atopic dermatitis, about 3 million children particularly with moderate to severe disease. That's a fairly staggering number. We don't have direct population-based estimates of the US prevalence of severe or moderate to severe AD in adults. And this is something, it's beyond the scope of this discussion, but there's a lot of technical challenges with nomenclature and other issues that have come up that have precluded the ability to look directly into claims or to even look at sometimes with population-based estimates. But if we do a little mental gymnastics and we pair together a number of different estimates together, you'll get to some number of around, from these population-based studies alone, you'll get to a number of somewhere around 0.7 million or so with severe atopic dermatitis who are being treated. Now, you could debate this number. We don't, and you should debate this number because we don't have those direct estimates, but it's probably somewhere in that ballpark. When you look in the German data sets, about 10% of atopic dermatitis patients in Germany were reported to have been treated with systemic therapy. So that may be a greater reflection of the moderate to severe population. I think, though, the penetration of use of systemics in Germany is very different than that in the United States and far greater. So, but this might be a reasonable proxy of severity. So now we're going to flip back over to psoriasis.
Okay, so how do we define psoriasis severity? There are also a number of different definitions for this. What I'm showing you here is the National Psoriasis Foundation definition based on body surface area involvement. And I think this is what the majority of us use in clinical practice. Certainly we see PASI in clinical trials, but nobody uses that in clinical practice. So based on body surface area involvement, 3 to 10% means moderate to severe or moderate disease, and severe is defined by greater than 10% involvement. Mild disease is less than 3% of the body surface area involved. I'm showing you here again the prevalence rates for mild, moderate, and severe disease, and you can see that 20% of patients are estimated to have moderate to severe disease, and we do have some population-based estimates of this. Now, we can also think about defining psoriasis severity in a different way. So one other way to think about this is whether or not somebody is a candidate for phototherapy or systemic therapy. What I'm showing you here is taken from our most recent, which is a little bit old, psoriasis guidelines from the AAD for treatment. And they break it down like this. So basically, candidates for phototherapy or systemic therapy can include more extensive body surface area involvement as defined by greater than 5%, but also less involvement based on body surface area, but sensitive area involvement, such as genitals, face, scalp, hands and feet, nails. Patients who report significant impact on their quality of life by their psoriasis and patients who are also failed localized or topical therapies can also be considered for systemic therapy or phototherapy. And certainly we know that patients with psoriatic arthritis have an indication for systemic therapy. As I alluded to before, despite an increasing number of efficacious therapies for psoriasis, most patients with psoriasis, especially moderate to severe disease, remain undertreated. And this is a similar problem that Jonathan talked about in atopic dermatitis. So we could certainly do a better job of treating our patients in both arenas. This is data taken from a multinational survey study of patients with psoriasis. And what I want to highlight here is that, see the mouse? Okay. So these two bars here on the right are patients with moderate and severe disease. And in the pink boxes, what I'm showing you here, the percentage of patients who are reporting that they are only being treated with either topical therapies or with no therapy at all. So this is definitely something that we should be improving on. Now, what sort of impact does this have on our epidemiologic studies and measurements of psoriasis severity, and certainly other studies of outcomes and such? So, in using large databases, often body surface area involvement is not recorded in a way that is easily extractable for us to study. And certainly, so we use surrogate measures of disease severity, and this is where it comes into play the idea of using systemic therapy or phototherapy as a surrogate measure of more severe disease. But certainly, as you can imagine, having moderate to severe psoriasis based on your body surface area involvement does not necessarily always mean that you're getting systemic therapies or phototherapy. And as you can see in the prior graph, most patients are undertreated. So there's probably a fair amount of misclassification where a lot of patients with severe disease defined by treatment, with mild disease divided by treatment probably have severe disease. So how does that impact our studies? So what I'm going to just show you here is estimates of moderate to severe disease from a United Kingdom population-based database, it's electronic medical record database, and differences in prevalence of moderate to severe disease based on different definitions. So if we look at the top, if we estimate moderate to severe disease based on therapy, so receipt of phototherapy or systemic therapies, the estimated prevalence is about 6%. Now, on the other hand, Joel Gelfand had created this cohort within this same database of a smaller number of psoriasis patients from which body surface area involvement was collected from general practitioners. And based on that direct body surface area involvement, interestingly, the prevalence of moderate to severe disease is much higher, 48%. So you can see how this can impact our studies, and I think Dr. Gelfand will be talking about how this also impacts the comorbidity studies.
All right, so let's talk a little bit about risk factors for atopic dermatitis. When trying to summarize this, I ran out of room on the slide because you're talking about an incredibly heterogeneous disease. And, I make the argument that atopic dermatitis may not be one disease, but really a spectrum of disease within itself, or a phenotype, if you will. But a lot of different directions in terms of risk factors have been implicated. Certainly from the genetic side of things, well established in terms of filaggrin null mutations being responsible. But really, even according to the best number, so to speak, explains only about 30 to 50% of cases in patients of Northern European descent or of Asian descent. Really doesn't explain the majority of cases even in those groups, and certainly doesn't explain high prevalence rates in patients of African descent, so African American or Afro-Caribbean, where there are virtually nil rates of filaggrin gene mutations. Numerous other isolated studies have found different mutations and polymorphisms in different genes. The question is how common these are, or how causative these really are. When we think about the inflammatory pathways, sort of going downstream from a mechanistic standpoint, whether or not you would argue these are risk factors, are there exogenous things that trigger these pathways? We know that IL-4, IL-13, and Th2 inflammation is getting a lot of attention. IL-31 in terms of itch and atopic dermatitis, interleukin-5 with eosinophilia and atopic dermatitis, and there's a number of other pathways that have recently been implicated as well. When we think about classically, this is a disease with barrier disruption, and you could argue the chicken or the egg on this, and there's certainly a lot of heated discussion that goes on at meetings over this point. But whether it's genetically predetermined filaggrin mutations, barrier disruption, or acquired, all patients have these barrier disruption, and this is something that leaves them predisposed to all of those exogenous factors. And so they have lower filaggrin, lower ceramides, lower antimicrobial peptides, higher transepidermal water loss. But when you look at the list of exogenous factors, they're huge. Certainly climate is one that we see very clinically relevant on all the time, and now we've done some population-based epi studies that have really confirmed this. Ultraviolet exposure within that same sort of class. Microbes, of course, there's a growing recognition of the role of microbiome in general, but how these microbes can really trigger the disease and what some of those early life exposures to microbes are, in line with hygiene hypothesis, but really not just in the early life in that sense, but really throughout life. Dietary exposures, some population-based data from the ISAC study suggesting that Western diet is associated with higher rates of the disease. We don't really understand that yet, but it's something that, diet, certainly patients are very concerned about this, and diet may in fact play a role for many. Could food allergy play a role? Well, certainly not in most, but in those patients who do have food allergies, maybe in younger children, patients who have facial reactions, etc., food allergens can be a source of reactions for some. Irritant exposures, a tremendous one. In terms of personal care products, water exposure, etc. Pruritogens, things that almost make them itchy, allergens, as I mentioned before, certainly airborne allergens, other contact allergens. Pollutants is one that there's lots of data out there internationally, but really unclear of how much this really drives the disease, but something that yet is known, at least in some cohorts, to play a major role. And then potentially even certain medications. We have this pattern of drug-induced eczema, which you could argue is really a different disease, but in fact, for many of my adult atopic dermatitis patients, ones who've had it lifelong, they're often on these medications, and there's a lot of questions about how much they play a role, if anything. Antibiotic exposure is another one because of its impact on microbiome, etc. And then there's a lot of behavioral factors as well. And these behavioral factors have been linked cross-sectionally to atopic dermatitis. And one of the challenges with them is the chicken or the egg. Is it that these risk factors are predisposing factors for atopic dermatitis, or vice versa? So there are studies with obesity that have shown that early life obesity is associated with higher odds of subsequently developing atopic dermatitis. So there, you'd think of obesity as a potential risk factor, at least in a subset, not necessarily in everyone, but in a subset. Yet on the flip side, patients with atopic dermatitis, particularly with moderate to severe disease, tend to be more sedentary, which is going to be a setup for them to potentially gain weight as well. And the same goes when you go down this list: smoking, alcohol. These are poor health behaviors that could be the sequelae of chronic disease, but certainly there are numbers of studies that have shown that these can actually be triggers for the disease as well. Stress. Stress is a big one. And this, it definitely goes both ways. We see this clinically. Patients will have a stressful event that will just set them off into a full body flare within 24 hours. But on the flip side, the disease itself also causes stress. So it's a vicious cycle in this sense. Some questions certainly about occupation, and it definitely will play a role because there's exposure to friction, to irritancy, et cetera, that may drive the disease. And then there's a lot of controversial data back and forth about whether or not breastfeeding is truly protective or not, if there's any benefit, or versus early life food exposure. So that's one that we still need a lot more data about. But what's fascinating about this is, and really exciting now, is that atopic dermatitis, at least in some, may be a preventable disease. And so this is based on just showing you sort of the setup of this. There's a number of studies that have shown this, but from this baseline study, which is a birth cohort, measured skin barrier function very early life, at 2 days and then at 2 and 6 months, and then looked at the subsequent development of atopic dermatitis and allergies. And in fact, turned out that higher transepidermal water loss at day 2, even before any visible disease, was predictive of developing atopic dermatitis and food allergy, suggesting that this early life barrier disruption, it may start at infancy, at birth, and it's something that will then eventually lead to the development of the inflammatory part of the disease. So theoretically, if you could intervene and sort of knock that out, could you in fact prevent the disease? And in fact, there are several studies now that have shown this. So I'm showing you one that was published by Eric Simpson, but there's another study that was published in the same edition in Journal of Allergy and Clinical Immunology, and this is looking at sort of a pilot study, if you will, of 124 neonates that were high risk for atopic dermatitis, and started to moisturize daily from about 3 weeks. And it almost didn't matter what you used to moisturize, but as long as there was adequate moisturizing, by 6 months of age, there was a 50% reduction in atopic dermatitis with no adverse events. And actually, one of our residents at Northwestern actually did a study looking at cost effectiveness of this, and really found that it's a very cost-effective strategy. But just to give you a sense, for $7 a year, you might be, or that 6-month period, you might be able to save on what is an exceedingly expensive disease. Now, there's a lot of unknowns about this because we don't know if this will persist, right? Maybe they'll get it at 5 years of age instead of 6 months of age. But that could still be enough to minimize the severity of the disease down the road. It could still be enough to minimize comorbidities from developing, et cetera. So this is a very exciting area as well. I'm going to turn it back now to psoriasis. Okay.
Okay, so similarly, psoriasis is a complex and multifactorial disease. There's certainly genetic and immune dysfunction components that contribute to developing this disease, which you'll hear more about later. And then we similarly also have environmental and behavioral risk factors, both as actual risk factors and then also sort of triggers or modifying factors of psoriasis, as Jonathan talked about for atopic dermatitis. The most established risk factors for psoriasis include obesity. What I'm showing you here are data from a Nurses' Health study of incident psoriasis, and you can see as BMI goes up, as we go down the table, the risk of developing psoriasis increases as well. Another way to look at this is at the very bottom. For every 1 unit increase in BMI, the risk of developing psoriasis increases by 5%. Smoking is the other very well-established risk factor for psoriasis as well. This is coming from similar data, Nurses' Health study, as well as the Health Professionals follow-up study. And again, this is a study of incident psoriasis in people who are increasing smoking pack years is associated with an increasing risk of developing psoriasis as well. Now, unlike atopic dermatitis, we don't have preventative studies for psoriasis at this time, so I'm a little bit jealous about that. So maybe that's coming down the line for psoriasis in the future. Here's a list of a number of other triggers for psoriasis. It's unsure whether these are actually risk factors, but that has been suggested in the literature. Infection, certainly we know about streptococcal pharyngitis and the development of gut-tape psoriasis, but certainly more data needed to understand whether these are true risk factors or triggers.
We're way over time. Okay, fine. So
We got two dynamics.
So we got two dynamic, exactly, dynamic duo. So you know what, I'm going to just spend 30 seconds whipping through this slide just to show basic concept here, which is, you know, certainly when you're looking at quality of life, the more severe disease, you'll see impacts on global function in terms of short form 36, physical function and mental functioning, but most of these quality of life measures really correlate very poorly with disease severity overall. But it's something that as you get into more of the skin-specific or disease-specific measures, you tend to see much more reliable correlations. And part of that is because really the burden of disease here comes from the symptom burden, which is often neglected from these global assessments. But in particular, just looking at sleep, sleep seems to be a major predictor of overall quality of life and something that we need to really watch over time.
Okay, in the interest of time, I think I will just highlight one slide on quality of life in psoriasis. So psoriasis has a major impact on our patients' quality of life. What I'm showing you here are scores from the SF-36 physical and mental health domains. You can see psoriasis has similar or even worse scores than a lot of other chronic diseases. So the impact of this just skin disease on our patients is really quite great. One other point here is that quality of life measures do not correlate with objective measures of disease severity. So this is an important aspect that we need to be asking our patients about. So, in summary.
All right. So, you know, we've seen a lot of similarities, but also a lot of differences. In terms of, you know, population-based prevalence, differences super common in children, but also turns out maybe not so rare in adults, and in fact a disease of adulthood as well. Higher prevalences in blacks, females, rural and urban areas. Most pediatric cases seem to begin in early childhood, and a subset will certainly persist into adulthood. But many adult cases seem to either begin or recur in adulthood, and that's going to be an important part for our epidemiology. Numerous risk factors to be thinking about, but some that are actually targetable now for interventions, and that really is exciting. And of course, a major impact on quality of life.
Okay, and to highlight just a few things about the psoriasis, you know, common inflammatory skin disease, predominantly a skin disease of European descent or whites. Lifelong waxing and waning chronic course, again, compared to atopic dermatitis, very much an adult disease. Obesity and smoking are some of the main risk factors for psoriasis and major impact on quality of life for our patients.
Okay, I think we are...
Okay, thank you very much.